I'm Dr. Aaron Kowaleski with ECCO Medical, here to talk to you today about uterine fibroids, as well as the treatment option we offer here at ECCO Medical, uterine fibroid embolization. In short, it's an outpatient, minimally invasive procedure without an incision that does not require general anesthesia. It's done outpatient, you walk in, you walk out, and it's covered by all insurance plans, including Medicare and Medicaid. What kind of symptoms do uterine fibroids cause? Well, the most common presenting symptom is going to be pelvic pain that gets worse with your cycle. There can also be heavier bleeding than normal or bleeding constantly that can result in anemia. Other things that can happen are bloating or constipation and urinary urgency if the fibroids are pressing on your bladder or rectum. These symptoms can show up all of a sudden or can slowly develop and get worse over time, depending on the size of your fibroids and the location. So who gets uterine fibroids? Well, obviously, in order to have fibroids, you have to have a uterus. So that means you do have to be a woman. So that's criteria number one. Criteria number two, age range is going to play a role. So this is during childbearing years. Usually they develop between the ages of 25 and 55. As far as how often do people get them, the more pregnancies, the more likely you are to get uterine fibroids. Over 55% of all women do develop fibroids in their lifetime. And the general rule is that the darker the skin color, the more likely you are to have uterine fibroids. Those of African descent are going to approach that 70% incidence of developing fibroids in their lifetime. The location of uterine fibroids within the uterus is important to understand, as it can determine which treatment option is the best one for you. So there are 3 layers to the uterus, and simply put, there's the outer layer, the middle layer, and the inner layer. Each layer is going to create a different kind of symptom. The outer layer may not produce pain or bleeding, but may produce those symptoms such as bloating or constipation or urinary frequency, because the tumor that's on the outside of the uterus could be pressing on your bladder or rectum. In the middle layer, which is the muscular layer, those are going to be more likely to cause pelvic pain and cramping because they are in the muscular layer, and so they can spasm just like a muscle anywhere else in your body. And especially they'll spasm more often during your cycle when there's increased estrogen stimulating them to contract, cramp, and spasm. The inner layer is going to be more likely to cause bleeding, as they are going to be just in under the endometrium, which is where the vascular tissue sloughs off on a monthly basis. This can increase bleeding, prolong bleeding, and also increase the likelihood of clot passage. So what's the appropriate workup for uterine fibroids? For the most part, uterine fibroids are diagnosed once an ultrasound is obtained that a gynecologist orders when a patient comes in complaining of the symptoms caused by fibroids. Ultrasound is a great screening tool. It lets you know that there are fibroids there. It is going to miss maybe multiple fibroids that it can't really see all that great, but it is a great screening tool. The best imaging study to fully evaluate uterine fibroids and to determine which the best treatment option is for you is going to be MRI. MRI lets us know the location of fibroids in significantly greater detail, which can certainly determine which treatment option is the best for you. One of the issues with MRI is that not every insurance plan covers it, and so you have to be selective with who you send to get MRIs, so that way they're not stuck with a bill or denials or anything like that. So for all our patients that come in, we attempt to at least get MRI on every single patient. However, there are some exceptions, maybe due to urgency or an inability for insurance to cover the MRI itself. There are 5 treatment options for uterine fibroids. Some of them depend on the symptoms you have, and like I mentioned earlier, it does depend on the location of these fibroids as to how effective these procedures will be. Not everyone is qualified for every single procedure. It does depend on size, number, location, etc., so we'll go through that. So the 5 treatment options that exist for fibroids are, first and foremost, birth control. Progesterone-based birth control is going to be able to decrease bleeding. This is not a treatment or a fix. This is usually something that's done to slow down bleeding, to get patients to a point where they can get a more definitive treatment. So again, it's non-invasive, but it's not an actual fix or definitive treatment option. Next up is going to be something called ablation, or ECCO is the brand name. This is when a needle is placed into the fibroid itself. That will either be placed through an incision in the belly, or they can go through the uterus itself. That needle is then hooked up to an energy source, and it's heated up and it burns the fibroid, thereby causing it to scar down, and symptoms should get better with that treatment. Limitations on that procedure are, one, it's quite a bit newer, so there's not a lot of data out there. It does show that it has pretty significant recurrence rates, but also not every insurance plan is covering that procedure yet. And then size and number is actually going to be the biggest limitation on what this sort of treatment can do for a patient. So if you have fibroids that are bigger than 2.5 or 3 centimeters, which is about an inch, radiofrequency ablation or ECCO is not going to be a good treatment option for you. If you have more than 3 fibroids, again, probably not going to be the best treatment option for you. This treatment option does lose its effectiveness with a larger fibroid and with the increased number of fibroids. Next on down the list is going to be your surgical options. First and foremost is myomectomy. Myomectomy is a surgery that is done at the hospital. It is done with general anesthesia, may or may not require a hospital stay depending on how the surgery goes. With myomectomy, multiple incisions can be made. They can do it robotically or laparoscopically. They go in and they simply remove the fibroid itself. So they keep the uterus intact if they can, and just remove the fibroid. Couple limitations here, that it does have a decent recurrence rate, specifically because if there are multiple fibroids, they may not be able to remove all of them. They may just remove what they can when they're in there. Secondly, the size of the fibroid can really determine the size of your incision. You can have small incisions to get to the uterus, but you got to remember you have to take the fibroid out. So if you have a large fibroid, 8 centimeters or larger, they are going to have to make a larger incision in order to get that out. Easy to get in, but depends on what you're taking out as far as the size of incision. Size of incision determines your recovery rate, complication rates, etc., etc. Another thing that can occur, if the fibroid is on the inner portion of the uterus, as discussed earlier, it can be very difficult for them to either get to that fibroid in the first place or to be able to get it all out. Therefore, you don't actually treat that fibroid in particular, so your symptoms may not go away after the surgery. That's not every time, but it can happen. Moving on down to the next surgical option is hysterectomy. Hysterectomy is just complete removal of the uterus. They can do that through an incision in the abdomen, or they can take it out transvaginally. Again, which one they choose is going to be based on the size of the uterus, the number of the fibroids, etc. If you have very large fibroids, that would mean a large incision, which would also cause a longer recovery and higher complication rates. Hysterectomy is also done at the hospital, also done with general anesthesia. About 1 in 5 patients that get a hysterectomy have a complication within the first 30 days after the surgery requiring hospitalization. It's not insignificant. It's not so it's something that definitely has to be considered. Recovery from this can also be months. Other things that have to be considered are pelvic floor issues. You can have pelvic floor weakness and require some rehab there after this sort of surgery. Moving into what I do, uterine fibroid embolization. This is not technically a surgery, as we're not cutting you open. We're not making an incision. We're just using needle punctures and image guidance. This procedure has been around for about 40 years now. The first one was done in 1995. So this isn't new. It's been around for quite some time. So let's talk about uterine fibroid embolization, the actual procedure itself, how it works, etc., etc. So this is a needle stick procedure only. There are no incisions made, so there's no stitches to get removed later. We don't have to open up anything to get to where we need to go to treat you. This is an outpatient procedure that's done in our office. We use moderate sedation. We do not need to use general anesthesia for this procedure. You walk in and you walk out. Technically, we will you out because you'll have some sedation on board, but you're able to walk. So the way this procedure is done is using X-ray and ultrasound guidance. So we do a needle puncture through the wrist. Okay, and I know that seems weird because everyone thinks, well, my pelvis is a ways away from my wrist. Why are you using that access site? The general concept in my field is I can stick anywhere you're in your body to get to anywhere else. I can stick your toe and get to your brain if I need to. We choose the access points, or what we call access points, that are going to be the lowest risk and the best patient experience. You can go through the groin to get into the pelvis. However, after that sort of access point, you do have to lay flat for 2 to 4 hours after the procedure. After any procedure, that can be a little bit difficult, especially something involving your uterus, which you may have some cramping, etc., and you may want to roll over and get in the fetal position. If we go through the groin, you don't have that ability because you have to lay flat. It can be very uncomfortable. If we go through the wrist, you can move over and get into any position you need to right away. You can go to the bathroom right afterwards, whatever you need to do. So let's talk about how we're able to do that. So first and foremost, we use ultrasound guidance to look at the artery in the wrist. I use the left radial artery. That's the pulse that you can feel right along below your thumb on the wrist. Can see that on ultrasound very easily. It's just underneath the skin. Numb up the skin. You're sedated at this point, so you don't really care. And then I stick a needle into that artery, and then through that needle, I thread a little tiny wire. I don't know how well you can see this on the camera, but it's very, very tiny. You know, not much bigger than a hair. That wire will go through the needle, up the arm. I can see this wire on x-ray, and then I can guide this wire up the arteries in the arm, up to the shoulder, and then I will take a left-hand turn and go down the aorta into the pelvis. Once that wire is down in the pelvis, I can then thread a little tiny tube over that wire. We call it a catheter. A lot of people think about a urinary catheter when they hear that word. Catheter is just any flexible tube. So the catheter I use is about 1.5 millimeters in diameter. So it's very, very small. So we thread that over the wire, goes up the arm, then down into the pelvis. Once I'm there, using x-ray guidance, I inject what's called contrast. Contrast is essentially an iodine-based salt water that flows with the blood. Iodine reflects x-rays so that way we can see it on screen. With the equipment we're using, I'm looking at the screen while I do this, and there's software that we use to, in real time, create a map of the blood vessels when we inject that contrast. That contrast flows with the blood. We're using live action x-rays so we can make a map of the blood vessels that are feeding the fibroids specifically. Once we've got that vascular map made, I can then use that wire catheter combination to navigate and steer into the blood vessel feeding the fibroid. And then once we're in there, I pull the wire out, and then through that catheter, I inject hundreds of thousands of tiny little beads, which will then flow with the blood into the capillary beds that are supplying the nutrition to the fibroid, creates a plug, and then cuts off the oxygen, starving the fibroid, causing it to shrink and die or go away altogether. So what are you in for on procedure day when you come to us to get treated? So you need to carve out about a half day to be here at our office. That is not the procedure time. So the procedure itself is actually going to be the shortest part of the day, but let's go through and break down time-wise what's going on when you come in. So you got to get here about an hour before the procedure starts. There's all the stuff that you have to do beforehand. Go to the bathroom, get your gown on, fill out paperwork, get an IV started, etc. All the normal pre-procedure stuff that you do for medicine. That takes about an hour, and then after that you go into the procedure room. The procedure is probably going to be the shortest part of the day. Procedure can take anywhere from 30 to 90 minutes, depends on your anatomy, how many fibroids we're treating, etc. Our average is going to be in that 30 to 45 minute range of actual procedure time. The longest part of your day is going to be recovery for a variety of reasons. Everyone's body processes sedation different. The medications we use have a very short half-life, so they are out of your system by the end of the day. But some people process them really quick. They may be ready to go 30 minutes after the procedure, and guess what? They go. So they'll have only been here for 2.5 hours. Other people need to take 2 or 3 hours to recover from the sedating medication, and that's okay. They can just stay, they can relax. Once they're ready to go, that's when they go. Another thing that can occur in recovery that can prolong your stay in the office, pain and nausea can start here in the office right when the procedure is done. We get everything managed here first before we send you home, so we don't just kick you to the curb if you're not feeling great. So about a half day is going to be how long you'll be at ECCO Medical, with the majority of that time in the recovery phase. So let's talk about the beads. A lot of people have questions about the beads because they wonder, what are they, what's going on? So let's go through the frequently asked questions, and hopefully this can answer whatever you've got on your mind. So the most commonly asked question that I get is, do these things dissolve once they're put in there? And the answer is no. These are a permanent implant that lodge themselves in the blood vessels feeding the fibroid, and they stay there. They usually get encased in scar tissue after a couple weeks to months after the procedure is done. So they stay there once they're injected and implanted. So once I say the word implant, everyone gets a little concerned and they start wondering, well, how much is going in? Well, it's not an implant like you would think about, like a saline implant or a hip implant or a knee implant, nothing that big. If from an actual volume standpoint, for patients to get a visual, if you know what a shot glass is, which, I just learned what one was recently. You have a shot glass, it wouldn't even fill an entire shot glass as far as the amount of beads that we're putting in. Another question is, can these beads move once they're implanted? And that answer is also no, and that's been proven with studies in the past. These beads, once they lodge themselves in those blood vessels, they do not move. 99% effectiveness, because nothing is 100%. Lastly, a lot of people want to know, what the heck are you injecting into my body? So there's a lot of companies that make beads, and every single one has a different formula, et cetera, et cetera. Some companies make glass beads, some companies make resin, others use plastic, others use rubber. The company that we use is the oldest one on the market that's been used for fibroids for the longest, longer than any other company out there. Theirs is what's called a synthetic polymer, meaning that they make their bead in a lab, and specifically they make it using it's actually an anti-inflammatory molecule that helps decrease the pain and swelling during the injection and afterwards. It is called sodium polymethacrylate, coated with polysine F. This bead has been used in uterine fibroid embolization for over 30 years, which is by far and away the longest of any bead that's out on the market. I am not a chemist. I do know that this bead in particular, I have not found a report of an adverse effect from the material in this bead as related to this procedure. Toxicity, I've never seen anything in the literature to show that this has a level of toxicity from this procedure as well. So in my experience and in experience of the literature that's out there, this is a completely safe bead, and it does help decrease inflammation due to the properties and the way they make it in the lab. Recovery of this procedure can vary per patient, just like any medical procedure in the world. So let's talk about worst case scenarios, which is what I like patients to be mentally prepared for. But please remember that worst case scenario means that this has only happened to 1 or 2 patients in my career, because worst means really the worst I've ever had. So I'm going to talk about that, and then we'll talk about what it's more likely to look like for you. Up to 72 hours of pelvic pain and cramping and nausea, and that's worst case scenario. Okay, up to 72 hours. We'll talk about how we manage that here in just a little bit. Once that pelvic cramping and nausea goes away, you can have up to 2 weeks of fatigue. This isn't debilitating fatigue where you're stuck in bed and you can't move and you can't even think. This is more like if someone calls you and says like, hey, let's go out to dinner tonight, then you'll say, you know what, I think I'd rather just stay in and Netflix and chill or something like that, rather than getting up and doing anything. You may not necessarily feel like working out. You're medically cleared to work out though after 5 to 7 days. So you just may not feel like it for a couple weeks. On average, our patients have more likely about 24 hours of discomfort and nausea after the procedure, and then that starts trailing off over the next couple days. That's more the reality, but I would like for patients to be mentally prepared for worst case. The length of fatigue can vary greatly. Some people are ready to rock and roll after a few days, and some people need the entire 2 weeks. As far as medical clearance to do things, the day after the procedure, you can get up, walk around, you can go to stores. You can't drive because you will be on some medications, which we'll talk about that here in just a moment. Medically, you're limited based on the puncture site in the wrist. What we don't want to do is have you moving your hand around constantly, doing heavy lifting, bending, all these other things, because that can increase the development of getting a clot in the artery or having that puncture site open up and you would get some bleeding. So we recommend 5 to 7 days of limited work and stress and motion with that wrist to allow that side to heal up. So you can use your other arm to do stuff, but we do want you to take it easy with that other one. If you have a job where you work from home and you do a lot of typing, recommendation there is just get an over-the-counter wrist brace, so that way when you are typing, you are keeping that hand straight, but you can start doing that the next day after the procedure. How do we manage the symptoms during your recovery? We use medications. The night before the procedure, we have you apply a pain patch. A pain patch takes about 12 hours to get to circulating levels, so we have you apply it the night before, so that way when you're leaving the procedure, you're starting to get that pain coverage from the patch. Any pain medication of any kind can also cause nausea with it, even if it's not to circulating levels. So we start having you take a nausea medication as soon as you apply that pain patch, so when you do get here on procedure day, you're not nauseated from the pain patch. After the procedure is over, we also have oral narcotics for breakthrough pain that the pain patch doesn't cover. We also prescribe additional nausea medication to make certain that that symptom, we can keep that at bay as much as possible. Nausea can keep people from hydrating, keep them from eating, and keep them from taking medications. We want you to stay hydrated. We want you to stay fed. We want you to be able to keep all your medications down, so that way this recovery period is pretty quick, a little bit low impact, and relatively easy on you. Other things we prescribe are an anti-inflammatory medication to further help with pain and to decrease any swelling that could occur in the uterus due to the treatment. We also prescribe an antibiotic for 14 days, which this brings us to the next thing that we're going to discuss, which are complications. An important thing to discuss with any patient are the potential complications of any medical procedure you do. The most common complication from uterine fibroid embolization does not occur on procedure day. It occurs within the first 10 days after the procedure, and that's an infection in the uterus itself, because that's where we did our work. Also, fibroids are sterile on the inside, but the endometrial layer of the uterus is not sterile. Bacteria can live there, yeast can live there, other things that are meant to be there to build a nutrient-rich environment for egg implantation. Fibroid itself is sterile though, so once you cut off the blood supply to it, the outer layers can start weakening, a crack can develop in that lining, and bacteria and yeast can get in there creating an infection. We prescribe you an antibiotic for 14 days to cover that time period and then some. Urinary tract infection is another infection that can also occur after getting sedation. Sometimes the bladder is not able to empty itself fully due to the sedation. That urine that gets retained can kind of be like a petri dish for an infection, so we cover for that at the same time utilizing the same antibiotic. Other complications that can occur are at the access point. Doesn't matter where you access, toe, groin, wrist, anytime you put a needle into any blood vessel, you can get a clot. That occurs very, very seldom in the wrist. However, it's not unheard of. It is documented. It has happened to a very few patients of mine. I believe 4 to be exact, with about 1,000 of these that I've done. Pretty low risk, however, it can happen. That leads to the little bit of a discussion of why we go through the wrist and how it's so safe. You have 3 arteries in your wrist that feed your hand, so if you do get a clot in one of them, you still have complete blood supply to the entire hand. Patients sometimes don't even know that they get that clot. Of the patients that get the clot, we put you on a blood thinner for about 30 days, and at least half of those patients, that clot goes away entirely, or the majority of it goes away. Long term, no issues with hand function or anything like that. And again, some patients don't even know they have it, and we find it later on down the road and they didn't even know. A little bit of a spiel on the medications that we prescribe patients for this procedure. It can seem like a lot. People have a lot of questions about narcotics, etc., and that's very understandable. This medication regimen that we use has been used for a long time. It's been evaluated by 2 hospital systems here locally. It's been evaluated by a toxicologist who specializes in drugs and overdoses, and it's also been evaluated by the Licensing Board of Colorado. It's been approved by everyone and deemed completely safe. So I can understand if there are some people that see this sort of thing, they can be a little bit alarmed, but please know that this is not something that I take lightly and that I take it very seriously. That being said, there are some patients that when we prescribe these medications, they either don't want to take the medications or they think that they're superheroes and don't need this stuff to get through this procedure. Of the patients that opt not to take what we prescribe or not follow the directions and take less, I would say that the vast majority of those patients do end up needing to go to the hospital for further pain management. When that occurs, they usually get admitted and put on IV narcotics rather than being able to recover at home. On the flip side, if you are a patient who thinks that maybe I didn't prescribe you enough medication and you should take more to double or even triple the dose, you will most likely also end up in the ER at that point, but most likely due to an overdose. I can say that if you take things as we prescribe them, this is a very safe medication regimen. And if you have any questions, please call us. We can adjust as appropriate. We can say, hey, take less. We can say, hey, take more. But please run everything by us because we're here for you to support you throughout this entire process. Another conversation to have as it pertains to this procedure is the idea of fertility. In some cases, patients have been deemed infertile due to the number and size of fibroids that they have, and I am shrinking these fibroids down in order to improve their chances of fertility by restoring a normal anatomy of the endometrium. Regardless, there have been no good studies about pregnancy following uterine fibroid embolization or really any other kind of uterine procedure for fibroids. It doesn't mean that you can't get pregnant. It doesn't mean that it's going to make it so you can get pregnant. It just means that there hasn't been a good study out there. There are some studies that are small, usually about 30 to 40 patients, that are more about pregnancy after uterine fibroid embolization and is the pregnancy safe? And so far, those studies, while small, have shown, yes, they are safe. The current recommendation, regardless of what you have, whether or not it's a cesarean section, a myomectomy, an Acessa ablation, or uterine fibroid embolization, is that if you get pregnant after the procedure, that you have an elective C-section 4 weeks before your due date. The reason being is because with these procedures, there's always a chance that there's been a weakening of the muscular layer of the uterus due to whatever, any incision made on it like a myomectomy, whether or not it's been burned like in the ablation, or maybe some of the blood supply had weakened the uterine wall from uterine fibroid embolization. This is just to ensure safety and health of the child. Either way, that is the recommendation. And every patient would be treated like a high-risk pregnancy regardless of age based on the fact that the uterus has been worked on before. Well, we covered a lot of info about uterine fibroid embolization. I look forward to seeing you for your upcoming appointment. Bring any and all questions or concerns you may still have. We're here for you and are dedicated to helping you feel better and get your best life back, symptom-free. I'm Dr. Kowaleski, and I look forward to seeing you soon.